Hello, and welcome to this clinical insight case discussion on the diagnosis of IPF. My name is Dr. Maryl Kreider from the University of Pennsylvania. I would like to thank my esteemed panel for joining us today. There are several things to consider when evaluating a patient for suspected IPF. This case will illustrate many aspects of the IPF diagnosis, especially the decision whether or not to send a patient for biopsy. To begin, this is a 69-year-old patient. So this is a 69-year-old retired road construction foreman. He has a 35-pack-year smoking history and quit over 20 years ago. He comes in noting 2 years of progressive dyspnea on exertion and a non-productive cough, and at this point, he becomes winded with about a quarter of a block of exertion. He has some mild GERD symptoms, but denies any associated joint, skin, eye, or other symptoms. He denies relevant exposures except for his job as a construction foreman. He has negative rheumatologic and hypersensitivity serologies. So based on this history alone, before we move to any imaging or anything else, what kinds of things are you worried about just from the history alone?
Well, I'm certainly worried about COPD. You know, he's a 69-year-old gentleman. He has a 35-pack-year history of smoking. He has shortness of breath and a cough. It's non-productive, so maybe it's not chronic bronchitis, but common things being common in a person with a 35-pack-year history of smoking, I'm going to think of COPD as first on my differential diagnosis.
I agree. I would add to that also his occupation. Construction work puts him at risk for silica exposure. So silicosis would certainly be, in addition to his COPD, a concern. Especially if he's seeing symptoms developing progressively more recently.
I think we want to make sure that we identify patients with idiopathic interstitial pneumonias, and of course his age, the fact that he's a male, not that both genders cannot be affected, but we see often idiopathic pulmonary fibrosis in males who are smokers or ex-smokers, and that's also a possibility.
How hard do you push on the occupational history? It's pretty common for people to come and say, yeah, I did some construction work. I have no idea what happened there. How in depth do you try and get?
Well, the most important part of the occupational history is simply identifying the occupation first. And the radiographic features, once we get an X-ray or a CT scan, will then, I think, either raise my suspicion or lower it based on radiographic features. Much of what we understand about occupational lung disease has been developed before the CT scan era and was heavily influenced by what we saw on chest X-rays. So I would certainly want to see a chest X-ray before I decided how far to, or which direction to go in terms of his occupational exposures. So I think simply being aware of it is an important part. I mean, construction work obviously is very common. There are many occupational diseases that can be much, much more subtle, like beryllium exposure, for example, where patients don't always provide you with this type of information, in which case you do have to delve in more carefully. But I think this would be enough for me to at least raise the question, and an X-ray or a CT scan would probably put it to rest pretty quickly.
And probably probe a little bit deeper too on, so what did you actually do on your day-to-day jobs? You know, were you a foreman that was, inside of a, the office setting doing most of your work, or were you actually on the front lines, and what did you do over time to try to clarify what, we have an idea of what a road construction worker is, right? We could have all said what we think he does, and it may be very different from what he was actually doing on a day-to-day basis.
This is tough detective work, so I agree that I would go into depth and discussion about what did he do. I often go also into military history, what they did when they were younger, were they in a shipyard. All those exposures could have implications for what they have today.
Well, before we move on to imaging, we're actually going to start with his pulmonary function tests. Could somebody take us through them?
So I always start with spirometric values, and I'm looking here at forced vital capacity, which is 77% of predicted, mildly diminished. His ratio, FEV1 to FVC ratio, is 79% of predicted, so it's normal. So the pattern is a restrictive pattern, and that's supported by his lung volume measurements and a striking reduction in his diffusion capacity at 30% of predicted, which is seemingly disproportionate to the amount of restriction we're seeing. We sometimes see that in athletes, but it raises the question of a mixed pattern, perhaps, someone that has both restriction and possibly emphysema on top of that, causing a disproportionate diminution of his diffusion capacity. So this really does tweak my curiosity about his imaging.
Makes me think of other things too that cause a disproportionately low DLCO. Right. These are corrected for hemoglobin, so we know it's not because of anemia, but he could have pulmonary hypertension. Certainly. His history doesn't suggest thromboembolic disease, but that could be there as well. So, and as you mentioned, the mixed patterns of combined emphysema and interstitial changes.
So let's move on to his imaging. What do you think?
I'm impressed with the cystic changes that I see some in the upper lobes. And as you go down on the images, you see quite a bit of these cystic changes and the approach of a honeycombing, perhaps mainly in the periphery of both lungs, but it starts quite high. In other words, it's throughout the lungs. At least you start seeing them in the upper lobes, and as you progress, you also see them. And there seems to be some ground glass opacification, but what's most striking is the periphery of these lungs have significant cystic changes consistent with honeycombing. Some of them are a little bit bigger than others and make me question about paraseptal emphysema, particularly in the anterior sides.
That's what I was thinking as well, particularly with the smoking history, but this combined pulmonary fibrosis and emphysema, where you do see some of these enlarged cystic spaces that just seem a little bit larger than some of the small, really neat honeycombing that we see when there isn't combined emphysema. So it makes me wonder about combination of patterns of a smoking history with obstructive physiology emphysema, as well as pulmonary fibrosis.
Yeah, the amount of ground glass is sort of hard to really discern because of the type of CT scan that we're looking at. It has a chalky appearance. And sometimes the MA settings on CT scans are such that it accentuates this type of chalkiness, and so it wasn't done with contrast, which would be a problem. But it makes it difficult for me to know how much ground glass change we're seeing. But it looks like a lot, and probably too much for me to be able to say for sure the pattern is a UIP pattern just based on the amount of ground glass we see, although all of the other features are present, the subpleural honeycomb change, the traction bronchiectasis, the thickening of the interlobar septi, the predominance of the disease in the mid to low lung zones is as much as we can see here would all go along with that. The amount of ground glass perhaps is a bit bothersome for me.
This is one where you really want to look at it with your radiologist and see, because as you pointed out, just by changing the windowing level,
that's right,
that ground glass could disappear.
I agree. This may be all technique, and
exactly.
We don't know
it
that.
certainly looks like this would be that type of CT scan where you adjust it and suddenly there's not nearly as much ground glass. But yeah, no, I agree.
Sometimes we've also noticed that when there is the presence of particularly paraseptal emphysema, but any emphysema, that the alterations caused by the emphysema then impact the distribution of the lung down at the bases as well, and so you get the sense of I think the blebs are pushing the normal lung and make it look more crowded and more like it's ground glass, when in fact it's just it's a geometry issue. So at this point, we have a gentleman with a concerning degree of physiologic impairment, this sort of vague history of construction foramen, and some CT features that are somewhat like typical of UIP, but not completely. How do you feel about biopsying him?
So one thing I would say that the CT scan findings certainly moved me away from most of the occupational diseases, even asbestos, although, because he lacks the pleural surface markers one would associate with asbestos exposure. I'm not sure how much of an exclusion that would be, but the next step for me, again, would be to think seriously about secondary causes. He doesn't have much in the way of symptoms. He certainly has a little bit of GERD. So a very, very careful exploration for autoimmune etiologies for his disease would still be appropriate, since that would influence whether or not we think a biopsy would be necessary. It might also explain if he had concomitant, pulmonary hypertension, for example, as a comorbid factor. I mean, I think I would look very, very carefully, and we tend to be very aggressive in looking at this. We tend to expand our autoimmune profiles to include all of the rare antisynthethases, all of the amyopathic myositis syndromes, as well as Sjogren's and the usual things, rheumatoid arthritis and a mixed connective tissue disease, and I wouldn't consider a biopsy until I had those results back.
Do you have a standardized pattern or serology pattern that you use, or is it very specific to the individual?
No, it's a general approach we take, and the approach is evolving as we get more studies available to us. So over the past 6 years, there have become available through research, through labs, clear certified tests to look for rare antisynthethases. There are 2 labs, probably more than 2 labs in the country, but 2 labs I'm aware of, one in Oklahoma and one in California. And what's interesting is that as we identify more of these rare antisynthethases, labs are upgrading their testing. So for example, an antisynthetase that probably represents less than 5% of the group, anti-KS is not represented in any of the usual labs, at least the clear certified labs. There are labs that do what we call immunoprecipitation and immunodiffusion assays that can get almost all of the autoantibodies we associate with myositis. Unfortunately, those labs, while they're clear certified and they are available, the turnaround time is very long. It could take 6 to 8 weeks for a result. So in a practical sense, I've not found those labs to be particularly helpful in a routine way of evaluating patients. If there's any question as to whether or not we believe there might be a rare antisynthetase, we'll seek those labs for validation. So I mean, to answer your question directly, I think there are routine myositis panels and scleroderma-associated antibodies that we can order that don't include probably 20% of the ones that we associate with interstitial lung disease, but I think it's a good start. We'll have to study the question. You know, are we looking too hard? Are we going too far? We've adopted the position as an ILD center to look as hard as we can, primarily because we want to get an appreciation for how important these things are, and more importantly, if we can avoid a lung biopsy by uncovering an autoimmune etiology, then we've done a patient a great service. And unfortunately, the clinical presentation doesn't help. Patients are often completely asymptomatic. I mean, he has some reflux disease. It certainly could be because he has advanced lung disease, but certainly that's certainly something that would raise the question of autoimmunity as well. But even in the absence of any symptoms, we often look very, very carefully, very comprehensively at the question of autoimmunity.
Yeah, it's interesting how the autoimmune-related interstitial lung diseases have emerged sort of a second or third tier of interstitial lung diseases that we look for. Do you also pursue a panel that is standardized for all your patients?
We're a little bit more conservative. So in this 69-year-old gentleman, if he doesn't have any signs or symptoms of autoimmune disease, we're probably not going to send a big panel just because of the cost and the pretest probability is lower. I think we need to study it more and know, as you said, should we be doing it in everyone?
That's right.
If he was younger, if we were a female, worry a little bit more, or if there were signs or symptoms. And again, the reflux could be that. But beyond that, we probably wouldn't send just an in-depth panel looking for myositis antibodies and the like.
When do you involve a rheumatologist?
So rheumatology is our rheumatologists are part of our multidisciplinary group, and particularly in patients in whom we have equivocal findings on an autoimmune panel, we can certainly get them engaged. They're always engaged. We've gotten, in fact, our rheumatologists have taught us how to look for rare autoimmune manifestations, and they're very much engaged in our discussions of, what do we do with the information we gather, which is always a big question. What do you do? How far do you go? And the diseases that we struggle with the most are Sjogren's syndrome. Sjogren's syndrome, we often are trying to accumulate evidence to support the diagnosis without actually having a test that points to it. So the lip biopsy might not be positive. There may be some inflammation, but not typical for Sjogren's. We might have positive elevation of gamma globulin fraction without any Sjogren's antibodies. Would probably positive less than 50% of patients. So we're always trying to accumulate evidence to support autoimmunity. And I'm surprised at how often we find it, even in the absence of any symptoms. And I would say especially the amyopathic myositis. A person who does this type of work in construction is likely to have mechanics' hands that are real mechanics' hands. Yeah. And I often encounter that, chips and ugly-looking fingers, and I say, well, looks like mechanics' hands to me. And he says, well, because I'm a mechanic. But we recognize, and as my personal experience, we find a lot of our amyopathic myositis patients have no clinical findings. I've had many of them that were followed by rheumatologists for psoriasis, and it turned out they had a rare antisynthetase. So again, we need research. We need to study this, and we've taken upon ourselves to order a lot of these tests, primarily as a way to try to understand the role of looking at these types of studies as part of, what's enough? And it's becoming more of a challenge because there's more things being identified. So, should we be getting MDA5 in everyone? Well, we don't, because it's too hard to get that test. Should we be getting, PMSCL on everybody? Well, we don't, because it's kind of hard to get that test. But we certainly do routinely look at JO1, as everyone does, I think, and PL12, PL7, some of the other antisynthetases. And we're often surprised at how often we encounter them in patients who are completely asymptomatic. They have no other findings. And that needs to be studied. Should we be looking routinely? I don't have the answer.
We see the other thing as well. In those, there's also that group of patients where we suspect that there's an autoimmune disease. We may send the serologic panel. It's negative, and that's also when we involve our rheumatologist.
That's right.
So it's actually a bona fide connective tissue disease, but it's seronegative, and should I, so I think the serologies can point us both ways. They may help us uncover disease that we weren't suspecting or that's asymptomatic, but sometimes they can mislead us by being falsely negative.
Yeah, it's interesting. In our multidisciplinary conference, this is the situation we end up discussing the most, is, what do you do when you either suspect it and it's not there, or it's there and you didn't suspect it? or
it looks like hypersensitive pneumonia and there's nothing you can find in the history.
That's right. Yeah.
So would you take this gentleman to biopsy?
So I don't think I would. If the items that we talked about came back negative, there wasn't something we could find in the history, I'm going to say that this is likely an idiopathic disease. If I look at the CT features, I think I can convince myself, particularly in a 69-year-old male, that there's patterns of usual interstitial pneumonia there. The disease is worse in the periphery and the lower lobes. There are areas of honeycombing. There's certainly reticulation. And the only caveat, as we discussed, of wanting to discuss with radiology is there a lot of ground glass? I think it's probably a technique issue here. So I'm going to say there's not a lot of ground glass. But if there was a lot of ground glass, then I'd flip-flop. I would say, I think we might need to get a biopsy in this one. But I'm looking at this as, for me, meets the criteria of UIP with peripheral lower lobe reticular change, with honeycombing, and without other atypical features like a lot of ground glass, mosaic attenuation, nodules.
Yeah, I'm impressed that probably only 25% of our patients with interstitial pneumonias or interstitial diseases actually undergo a lung biopsy, depending on the center. Is that your experience as well?
Yeah. I think we're getting better at understanding CT scans. There's still a lot of reflux, interstitial lung disease, got to get a biopsy behaviors, sure. I think. But I would add one thing to what Kevin said, and I agree with him. I think that this is likely going to be a very nice pattern for UIP. And in fact, if we saw ground glass, I would be worried that we may be catching this guy in an acute exacerbation. Sure. I would be so convinced that the underlying pattern is UIP that if I saw lots of ground glass, we've had the misfortune of biopsying patients, and the pathologist tells us, well, I see a little bit of diffuse alveolar damage, and we kind of go, uh-oh. And those are the patients that don't leave the hospital after biopsy. So I would agree. I think this is more likely going to be a UIP pattern. and I would be worried that if there is much ground glass that perhaps this patient is going through an acute exacerbation. I don't think so, but I would worry about that if I saw that.
And a biopsy can promote the development of exacerbation, or at least there's some data to suggest that. And one of the things that I mentioned to my patients is that sometimes we will not have the certainty of a biopsy, and that because of comorbidities or age and other problems, it may be better off to make decisions about diagnosis and treatment in the absence of histology. And there's some degree of uncertainty that we have to live with in order to prevent other problems with the surgical procedure.
All right. Well, I would like to thank my panel for joining us today to talk about issues about CAT scanning and how we should examine them, and also when we should think about doing biopsies. And I will be sure to send very careful collagen vascular serologies. Thank you.